Welcome. You've joined us for another deep dive, and today we're focusing on, well, a really crucial aspect of women's health.
Mhm.
We're looking at the gynecologic issues that can be more prevalent or maybe present differently in women living with HIV.
That's right.
Our main source for this is a detailed article from 2003. It's called Gynecologic Issues in the HIV-Infected Woman by Dr. Helen E. Sedchin. It was in Obstetrics and Gynecology Clinics of North
A
America.
foundational piece, really, even though it's from '03.
Exactly. And our mission for you, the listener, is to sort of unpack this information. We want to understand the key gynecologic considerations for HIV-positive women, pulling out what's most important, maybe even surprising.
Yeah.
We'll be covering things like menstrual disorders, the complexities of changes in the lower genital tract, specific thoughts on contraception.
And STIs, how treatment might differ.
Right, STIs too, though we won't focus heavily on general pelvic infections unless HIV, changes the standard treatment approach.
It's really about getting into the nuances, isn't it? How HIV interacts with these common conditions and their management.
Precisely. That interaction between the immune system, hormones, susceptibility, it's all linked.
It really is. This article gives us a solid framework for understanding those connections.
Okay, so let's dive right into menstrual disorders first. Now, people might have heard that HIV can affect a woman's cycle,
hmm And many HIV-infected women do report changes. That's true.
but it sounds like it's often not as simple as just saying, oh, HIV caused this.
Exactly. When you dig into why cycles might change, there are often several factors working together. It's not just the virus itself in many cases.
Like what kind of factors?
Well, the article points out that, unfortunately, in the U.S. context back then, HIV-infected women often faced higher rates of poverty and illicit drug use.
And those can affect menstruation?
Yes, both can sometimes lead to amenorrhea. That's when periods stop completely.
Okay. That makes sense from an overall health perspective. It's not just external stuff either, right? Mental health plays a role.
Absolutely. Co-occurring psychiatric illness and, the medications used to treat them, those can also be a cause of amenorrhea in this population.
And stress. I imagine that's a factor too.
A big one. The article mentions higher stress levels can disrupt the body's hormonal signaling pathways. Things like corticotropin-releasing factor, gonadotropin-releasing hormone. Basically, the messengers get interrupted.
Leading to amenorrhea again.
That's right. It's a common pathway.
Here's something else interesting you mentioned from the article, thrombocytopenia. Low platelets.
Yeah, low platelet counts. This can be due to HIV itself or sometimes certain older antiretroviral therapies like Indinavir.
And that could cause bleeding issues.
Potentially, yes. Maybe heavier periods, what doctors call menorrhagia, or bleeding between periods, metrorrhagia. It's a possible link.
And we also have to remember associated health conditions.
Exactly. Things like kidney problems, liver disease. These can sometimes be more common in individuals with HIV.
And they affect periods too.
They certainly can.
Yeah.
Especially liver disease, often linked with amenorrhea. The article even mentions a specific case report,
Oh, yeah.
a 14-year-old girl on HAART that's the highly active antiretroviral therapy who developed symptoms like polycystic ovaries on ultrasound, amenorrhea, acne, and hirsutism after about a year on treatment.
Wow. So lots of potential contributing factors.
Definitely. And another major one, especially back then, was severe weight loss,
Right. That used to be a much bigger issue.
a very common complication. One study cited found it affected about a third of HIV-positive individuals looked at, and significant weight loss is a known trigger for amenorrhea.
So this brings us to the really big question. Can HIV infection itself, without severe illness or major weight loss, cause amenorrhea directly?
That's the million-dollar question the research tries to answer. The article reviews several studies, and honestly, the picture is a bit mixed.
Okay, tell me about that.
Well, there was a study by Grinspoon and colleagues. They looked back at reports from 31 HIV-infected women. They found a higher prevalence of amenorrhea, about 20%, compared to the general population rate of around 5%. And that rate jumped to 38% in the women who were underweight.
But what about those who weren't underweight?
Interestingly, they still saw amenorrhea in about 17% of the non-wasting women. And they linked it in those cases to decreased muscle mass and lower levels of the hormone estradiol.
Okay, but that's one study. What else?
Yeah, then there's the Churgwin study. Larger, compared 248 HIV-positive women without AIDS to HIV-negative controls.
And what did they find?
They did find a statistically significant increase in amenorrhea in the HIV-infected women, 5%, versus 0% in the controls, even after accounting for other factors.
But 5%, that's still pretty low, isn't it?
It is. It's still within the range considered normal for the general population. And importantly, in their analysis, they didn't find a link between amenorrhea and CD4 count or having milder HIV symptoms.
So not necessarily linked to how advanced the HIV was in that study?
Not in their multivariate analysis, no. They did note something else, though. The HIV-positive women reported fewer premenstrual symptoms.
Fewer PMS symptoms, why would that be?
The researchers suggested it might be because they were having more anovulatory cycles where an egg isn't released.
Interesting. But then you said the picture was mixed.
Right, because other studies contrast with these findings. The article mentions a large prospective study, one that used detailed menstrual diaries.
Okay, that sounds more rigorous.
It compared over 800 HIV-positive women with about 270 HIV-negative women, carefully controlling for BMI, substance use, age.
And the result?
No significant difference in amenorrhea rates between the groups. Prevalence was actually low in both.
No difference at all.
Well, they did note a trend. The HIV-positive women with high viral loads and low CD4 counts tended towards shorter cycles and more variability in cycle length.
Ah, so maybe the level of immune suppression or viral activity does matter.
It seems plausible. Another study specifically compared women with CD4 counts between 200-500 to those with counts under 100.
And the difference?
Amenorrhea prevalence was 9% in the moderate group, but 19% in the group with CD4 counts below 100. That strongly suggests a link between more severe immunosuppression and period stopping.
So it seems like maybe HIV alone isn't the primary driver unless the immune system is significantly weakened or there's weight loss involved.
That seems to be the general conclusion, yes. Without those other factors, HIV itself might not directly cause amenorrhea in most women.
What about hormonal changes, though? Could HIV directly affect hormone levels?
That's definitely been investigated. We know, for instance, that HIV-infected men often have issues like low testosterone and problems with the hypothalamic pituitary axis, the brain-testes connection.
So researchers wondered if something similar happens with the ovaries in women.
Exactly. And studies have shown decreases in testosterone levels in HIV-positive women, even those without wasting.
Really?
Yes. In fact, HIV is now recognized as a cause of something called female androgen deficiency syndrome.
And that has consequences.
It's been linked to reduced bone density, particularly in women experiencing wasting who are also androgen deficient.
Okay. And ovulation. You mentioned the Churgwin study hinted at more anovulatory cycles. What's the consensus there?
Again, it's a bit mixed. Anovulatory cycles happen in healthy women too, maybe 5 to 30-something%, depending on the study.
Right.
Some small studies in HIV-infected women reported higher rates, like 48% in one, sometimes trending with lower CD4 counts. Another found it in almost a third.
But larger studies.
A larger one, involving 55 HIV-infected women and 10 controls, actually found ovulatory cycles in 96% of the HIV-positive women, compared to 78% of the controls in that particular study.
So maybe not a huge difference overall for women with regular cycles.
Currently, the thinking is that HIV-positive women with regular menses probably don't have significantly more anovulatory cycles than the general population, but the article does caution we lack really definitive large-scale studies on this.
Got it. And just quickly, what about menopause? Any link to premature menopause or FSH levels?
There's some data suggesting maybe slightly increased FSH levels in HIV-positive women. One small study even found menopause-level FSH in about 8% of HIV-positive women aged just 20-42.
But not enough to draw firm conclusions.
No, the article concludes there isn't sufficient data to definitively link HIV infection itself to premature ovarian failure.
And diagnosing menopause can be tricky anyway.
Especially in this population, yes. Amenorrhea could be from wasting, not menopause. And climacteric symptoms, hot flashes, sleep issues can overlap with other illnesses or even side effects from HIV meds, like efavirenz.
Although older HIV-infected women do report more menopause symptoms.
They do, yes. More menopause-associated symptoms are reported in that group.
Okay, so let's sum up this section on menstrual disorders. While changes, especially amenorrhea, can be common.
It's usually not just HIV unless other things are going on, advanced immunosuppression, weight loss, other medical conditions, medications.
Right. And evaluating amenorrhea should follow general guidelines, but checking FSH might help if menopause is suspected. Okay, let's move on to a really significant area. Lower genital tract neoplasia, precancerous changes.
Yes, This is where the link between HIV and gynecologic health becomes very stark. A major development was in 1993.
What happened then?
Invasive cervical cancer actually became an AIDS-defining condition.
Wow.
And even moderate to severe cervical dysplasia, those precancerous changes were listed as conditions potentially complicated by HIV. That really underscored the seriousness.
Why the change? What did the research show?
It stemmed from research in the early 90s showing a clear increased prevalence of cervical dysplasia in women with HIV.
More dysplasia, but not necessarily more cancer at that point.
The link with invasive cancer wasn't quite as firmly established then, but the connection with the precursors, the dysplasia, was strong. We already knew immunosuppression was a risk factor from organ transplant patients.
Right, they have higher rates.
Exactly. So it stood to reason the risk would likely be even higher in HIV-infected women, especially with shared risk factors like HPV exposure from multiple partners, plus the HIV-related immunosuppression itself.
And later studies confirm this.
Repeatedly, studies looking at cervical histology tissue samples and cytology pap smears consistently show a higher prevalence of these squamous intraepithelial lesions, as ILs, in HIV-infected women.
Are there numbers on how much higher the risk is?
A meta-analysis combining 15 studies found an odds ratio of nearly 9. So almost 9 times the odds of cervical neoplasias in HIV-infected women, and the risk seemed to climb with worsening immunosuppression.
That's a huge increase. What about those big U.S. cohort studies, WIHS and HERS?
They provided more concrete prevalence data. They found SILs on pap smears in about 17–18% of the HIV-infected women, compared to only 3–5% in HIV-negative women, even though they had similar risk profiles otherwise.
So a major difference.
A major difference. The HIV-positive women also had higher rates of ASIAs, those atypical cells, around 18–21%. But importantly, the rates of high-grade SILs and actual cancer remained relatively low, under 3% in both cohorts in those studies.
Any other factors linked to SILs besides HIV?
One study noted a potential link between increased SILs and retinol deficiency, which is related to vitamin A.
But the main driver seems to be the interaction with the immune system.
Definitely. In most studies, abnormal cytology and histology are independently associated with the degree of immunosuppression. How low the CD4 count is.
Can you give an example?
Sure. The HERS study broke it down nicely. HIV-infected women with CD4 counts above 500, relatively healthy, had SIL rates similar to the HIV-negative controls.
Oh.
But women with CD4 counts at or below 100, they had much higher rates of low-grade SILs. And the prevalence of high-grade SILs, the more concerning ones, was as high as 11% in that very immunosuppressed group.
And this increased risk isn't just a one-time thing, it persists.
That's right. Follow-up studies tracking women over years confirmed this. One cohort found new histologically confirmed lesions developed in 20% of HIV-infected women over 3 years, versus only 5% in uninfected women. Most of these new lesions in the HIV-positive group were low-grade, though.
Similar findings with pap smears over time.
Yes, another cohort saw similar results looking just at cytology. Again, the incidence of new high-grade lesions was low in both groups overall. The risk of getting a new SIL depended on HIV status, HEPV status, CD4 count, and HIV RNA level, the viral load.
What about progression? Do lesions get worse faster in HIV-positive women?
One study looked at progression over 6 months. It was higher in seropositive women, 14% versus 7%. But interestingly, in the detailed analysis, the main risk factors for progression were HPV status and HIV viral load, not HIV status itself directly.
And regression? Do lesions go away?
Yes, regression to less severe cytology was actually common in both groups, 43% in HIV positive, 66% in HIV negative.
And what predicted regression?
Similar factors, HPV status, HIV viral load, and also independently CD4 counts. Higher CD4 counts were linked to regression. Again, HIV status alone wasn't the deciding factor for progression or regression in that analysis.
Okay, now heart. The big change in HIV treatment. What effect did that have on SELs? You mentioned earlier it's complex.
It really is. The hope was, obviously, that improving immunity with heart would decrease cells.
Makes sense.
But the flip side was the concern that by extending lifespan, women would have longer cumulative exposure to HPV, potentially increasing cell risk over time.
So what did the data show? Did cancer rates drop?
Some studies noted that the incidence of invasive cervical carcinoma didn't decrease significantly after heart became widespread, and survival increases for those with cancer were small, maybe not statistically significant. So the overall impact on malignancies is still, well, not fully understood.
But were there any signs heart helped with precancerous lesions?
There were hints. One small study showed a trend, though not statistically significant, toward fewer new cells in women on heart with normal baseline cytology compared to untreated women.
Okay, a trend. Anything else?
Other uncontrolled studies suggested high rates of cells regressing after starting heart. Women seemed to clear the lesions better.
But controlled trials.
One prospective trial looked at women who already had cells. It found basically equivalent rates of progression or regression, whether women were on no therapy, older drugs, or heart.
So, no benefit there.
But then another large study did show a significant increase in regression and decrease in progression associated with heart use. So, conflicting evidence.
Why the difference?
It's likely complex. The main idea is immune reconstitution are cracked. Heart helps the immune system fight HPV better. But some researchers also proposed a direct antiviral effect of some heart drugs on HPV itself. That's less proven, though.
Let's talk more about HPV, human papillomavirus. It's the main cause of cervical dysplasia, right?
Absolutely. In HIV-negative women, most risk factors like multiple partners primarily increase risk by increasing the chance of acquiring HPV.
And the link between HPV and HIV is strong.
Very strong, though intricate. Longitudinal studies show HIV-infected women are more likely to have cervical HPV, all types, low, medium, high risk.
And it sticks around longer.
Yes, they're more likely to have persistent HPV infections and tend to have higher viral signals, more virus present.
Does the HIV severity matter for HPV persistence?
Yes, persistence seems linked to having CD4 counts under 200, and having HPV present is associated with increased progression and decreased regression of SIs.
So HPV is really the direct driver of the SILs.
It's believed to be much more directly linked than HIV alone. One analysis attributed over 70% of SILs in duly infected women directly to HPV, and only about 20% to HIV itself.
What are the prevalence numbers for HPV in these big cohorts?
In WIHS and HERS, HPV prevalence was around 65% in the HIV-positive women, compared to about 30% in the HIV-negative women.
That's more than double.
Yes. Now, interestingly, looking at HPV-16 serology antibodies showing past exposure HIV-infected women were much more likely to be positive, 53–56%. This was strongly linked to lifetime number of sex partners in all women.
But active infection.
When they tested for actual HPV-16 virus in the cervix using PCR, the rate was only around 5–6% in the HIV-positive women.
So lots of past exposure, but maybe less active replication at the cervix.
It suggests reactivation might be uncommon, and replication might still be somewhat controlled locally, even with immunocompromise.
How exactly do HIV and HPV interact? What are the proposed mechanisms?
Two main ideas. First, HIV-induced immunosuppression just makes it harder to clear HPV, letting it persist and cause trouble.
And the evidence for that?
The fact that women with high CD4 counts over 500 don't have that increased SI risk, and that non-HIV immunosuppressed people, like transplant recipients, do have increased SI risk.
Makes sense. What's the second idea?
A possible direct interaction between the viruses. In lab settings, in vitro, a protein from HIV called TAT1 has been shown to increase the expression of regulatory genes in HPV-16. It basically turns up HPV activity.
Any evidence in actual human tissue?
Cervical biopsy studies have found that HIV-positive women with SILs have significantly fewer Langerhans cells, important immune cells, compared to matched HIV-negative women. This was linked to CD4 counts.
Fewer immune defenders.
Yes. And fewer macrophages, too. Plus, they found a unique type of immune cell cluster, a CD8 lymphoid aggregate, only in biopsies from HIV-positive women with high-grade SILs. It suggests local immunity in the cervix is definitely impaired.
Okay, this all leads to screening. How should we screen HIV-infected women for cervical dysplasia? There was debate early on, right?
There was. Early concerns focused on whether pap smears, cytology, were reliable. Some worried about more inadequate samples due to inflammation.
Similar to the issues seen in transplant patients.
Exactly, where high false negative rates were known. One small early study reported a very high SIL prevalence, 41%, but cytology only picked up 7.7% in 32 seropositive women.
That sounds bad.
It led to an early recommendation, now unsupported, for baseline colposcopy and twice-yearly PAPs for everyone.
But that changed.
Yes. Further, larger studies indicated that cytology is an adequate screening tool in this population. It works reasonably well.
What about the correlation between PAP, colposcopy, and biopsy?
One study suggested the correlation might be poorer, but it was actually similar in both HIV-positive and HIV-negative women. Another small Italian study even found cytology more accurate than the doctor's visual impression during colposcopy in seropositive women.
So what's the current recommendation?
The U.S. Public Health Service guideline mentioned in the article was 2 cytologic studies, Pap smears, in the first year after HIV diagnosis, then yearly if those are normal.
Is that cost effective?
Analyses suggest that regimen provides a small increase in life expectancy at a reasonable cost per quality-adjusted life year.
Doing PAPs more often, like every 6 months.
Minimal added benefit at a much higher cost, according to those analyses. Extreme regimens like semi-annual colposcopy were very costly with little added value.
What about adding HPV testing?
Adding HPV testing to the initial cytology and then adjusting follow-up based on both results actually appeared more cost-effective, similar to findings in the general population now.
And anal cytology.
Routine anal cytology in HIV-infected women was not recommended at the time of the article.
Okay. So if screening detects an abnormality, how is it diagnosed and treated?
Diagnosis relies on colposcopy, that magnified view of the cervix with biopsies directed at any abnormal areas. Colposcopy is recommended even after a single Pap showing atypia or low-grade lesions.
Is colposcopy as accurate in this group?
Maybe slightly less predictive. One analysis found that almost half, 47% of seropositive women with high-grade lesions found on a later cone biopsy only had low-grade lesions seen on the initial colposcopic biopsy.
Compared to?
Only 9% of seronegative controls had that happen.
So what does that mean for practice?
It suggests being liberal with biopsies. If an area looks abnormal during colposcopy, biopsy it, even if it doesn't look classically high-grade.
And remember other areas too.
Absolutely. Higher prevalence of vulvar, vaginal, and anal precancerous lesions means careful examination of those sites is crucial, with colposcopy and biopsy of anything suspicious there too.
For treatment, are excisional methods preferred, like LEAP or cone biopsy?
Probably yes, given the potentially lower sensitivity of colposcopy. Better to remove the whole area than rely solely on destroying it in place, ablation, like with cryotherapy or laser.
What about complications, more bleeding or infection?
Some early suggestions of that, but the literature reviewed lacks strong supporting data. One study found no complications after hysterectomy for carcinoma in situ.
But cryotherapy might not work as well.
One study showed a much higher recurrence rate for low-grade lesions after cryotherapy in seropositive women, 48%, versus just 1% in seronegative women. That strongly suggests alternative therapies are better for them.
What about just observing low-grade lesions?
That's often appropriate, especially for lesions on the outer cervix, ectocervical. Cytologic regression is common in HIV-infected women. An ACTG study actually compared observation versus oral isotretinoin for proven low-grade lesions. Observation alone had similar rates of regression and low progression rates, so watchful waiting is often a reasonable approach for low-grade SILs.
Follow-up adherence is a concern, though.
A big concern. Studies cited showed adherence rates between 35–63%. That reality has to factor into treatment planning. Maybe a single treatment procedure is better than relying on multiple follow-up visits for observation.
And recurrence rates after treatment for high-grade lesions.
They are higher in seropositive women, unfortunately. But the approach to treating high-grade lesions is generally similar to the general population.
Though one study showed high recurrence even after definitive treatment.
Yes, a study of 45 HIV-positive women with cervical carcinoma in situ showed a 65% recurrence rate by cytology after both cone biopsy and hysterectomy. It's a persistent problem.
Any way to reduce recurrence?
An ACTG study offered a potential option. Women randomized to use vaginal 5-fluorouracil cream after excisional treatment for high-grade lesions had fewer recurrences and a longer time before recurrence compared to an observation group.
Did it eliminate recurrence?
No, the rate in the treatment group was still substantial, 28%. But it makes 5FU an alternative to consider, especially for recurrent disease.
Wow, that's a lot to consider for lower genital tract issues. Let's switch gears now to contraception. As the article notes, it serves two key roles here.
Absolutely. It's not just pregnancy prevention. It's also crucial for preventing HIV and STI transmission to partners.
So choosing a method involves weighing several things.
Definitely. Efficacy for pregnancy, efficacy for transmission prevention, potential drug interactions with HIV meds, and any effects the contraceptive method might have on the HIV infection itself. It's a balancing act.
And you made a crucial point earlier. Undetectable blood viral load doesn't mean zero transmission risk.
A really critical reminder. While blood levels correlate generally with cervicovaginal levels, a significant portion, maybe 20–35% of women with undetectable virus in blood can still have detectable HIV in cervicovaginal lavage samples.
So they can still transmit.
Yes, the potential is still there.
Okay, let's talk methods. Condoms first.
Widely used, especially by HIV-positive women with HIV-negative partners. Dual purpose, birth control, and transmission prevention.
How effective?
Pregnancy failure rates are there maybe 12% first year typical use, 3% perfect use, but they're good for transmission prevention. They block HIV in vitro, and a meta-analysis showed a 69% decrease in transmission risk with consistent use.
But consistency is key, and reporting isn't always accurate.
Right. One study of HIV discordant couples found significant underreporting of sex without condoms. Another European study followed 123 such couples.
And found
4.8 seroconversions per 100-person years with inconsistent condom use, but 0 seroconversions with consistent use over 22 months.
that's compelling. And transmission is usually easier male to female.
Generally, yes, though there are exceptions in Africa and developing nations. This highlights the need to identify and counsel women at higher risk for poor condoms, use those facing economic hardship, dependency, substance use issues.
And women who's had tubal ligations use condoms less.
Significantly less, yes. Only about a fifth as likely as unsterilized women, according to one study cited.
What about seroconcordant couples, both partners HIV positive?
Condoms are still advised then, too. Prevents other STIs and potentially reinfection with different HIV strains. The one study showed decreased use in such couples without apparent harm to their HIV progression or survival.
Do condoms help with HPV?
They don't prevent initial genital HPV infection, but a meta-analysis suggested they may decrease the risk of getting condyloma, warts, or high-grade cervical disease from HPV.
Okay. What about the female condom?
Prevents HIV in vitro, yes, but the post-year failure rate for pregnancy is higher, around 26%, often due to the ring slipping.
And spermicides, like nonoxynol 9.
They inactivate HIV in the lab, but don't seem to decrease the actual amount of HIV in genital fluids in vivo. Primate studies showed decreased seroconversion, but human studies are conflicting.
Some studies even showed harm.
A Kenyan study in sex workers actually found increased HIV transmission with spermicide sponge use. The theory was inflammation or ulcers from frequent use. This led the CDC to be hesitant about recommending them for HIV prevention.
Even though reanalysis suggested some protection?
Yes, a reanalysis hinted at protection. But a meta-analysis gave conflicting results overall. Newer spermicides, like one with iodocaraginin, were being tested, showing less irritation in early trials.
Good to know. What about diaphragms, sponges, cervical caps?
The article is clear. These do not prevent HIV transmission, and importantly, HIV can be transmitted transvaginally even without a cervix present.
Really?
Primate studies showed this, and there was a case report of sexual HIV acquisition through a neovagina in a woman born without a cervix. So just covering the cervix isn't sufficient.
Okay. Permanent sterilization, tubal ligation, or vasectomy?
A choice for many couples, both discordant and concordant. Interestingly, though, the desire for fertility has increased since the pre-heart era due to better life expectancy and lower vertical transmission risks now.
But tubal ligation is linked to less condom use?
Yes, over half of sterilized women in one study didn't plan to continue condoms and vasectomy in men. Some studies showed decreased seminal HIV afterwards, but it wasn't consistent or reliable for prevention.
What about IUDs, the trigger-in devices? You mentioned theoretical concerns.
Yes. Longer, heavier menses potentially increasing transmission risk.
Uh,
Also, theoretical decreased efficacy in immunocompromised women may be linked to anemia or increased pelvic infections. The WHO advised against them for HIV-infected women based on these theories.
but real-world data.
A Kenyan study of over 600 women without active pelvic infections or high risk found no increased complications, infectious or otherwise, in HIV-positive women, regardless of CD4 count, after 4 months of IUD use.
So maybe safe in carefully selected women?
It suggests potential safety in that context, yes.
Aye.
Another European study found no female-to-male transmission in IUD users, and a study of 98 HIV-positive users showed no difference in cervical HIV shedding before and after insertion.
Okay, let's talk hormonal methods. Oral contraceptive pills, OCPs. Theoretical concerns here too.
Yes. Could they increase transmission? One idea is through cervical ectopi changes to the cervix surface, possibly increasing viral shedding.
But counteracting factors.
Right. Maybe decreased bleeding or increased cervical mucus viscosity could decrease transmission. Vaginal pH changes might increase it. It's complex.
What does the overall evidence say about OCPs and transmission?
A meta-analysis found no definitive association. The main issue identified was the known inverse relationship between OCP use and condom use. That holds true for HIV-infected women, too. Less than half on OCPs reported using condoms concurrently.
What about effects on the HIV infection itself? Do hormones affect the immune system?
That's been a concern. Female hormones can impact cell-mediated immunity NK cells, antibodies. Animal models show hormonal regulation of retroviruses. A primate study suggested harm from progesterone implants.
Increased SIV transmission and progression.
Yes, in overreactomized monkeys given progesterone. But then, data from human menstrual cycles shows viral load actually tends to decrease during the high progesterone luteal phase, so conflicting signals.
Similar concerns for other hormonal methods like Depo-Provera.
Yes, plus worries about increased bleeding with depot possibly affecting transmission. However, a more recent study found no change in viral load and only a clinically unimportant increase in CD4 counts in seropositive women using hormonal contraception.
And pregnancy data is reassuring.
Abundant data on pregnancy in HIV-positive women suggests hormone exposure doesn't negatively affect disease progression overall.
But the biggest issue with hormonal contraception is drug interactions, right?
Absolutely critical. HIV medications metabolized by the liver's cytochrome P450 system can alter hormone levels from contraceptives, potentially making them less effective.
Like which drugs?
This is well known for rifampin, for TB, and several antiretrovirals, NNRTIs, and protease inhibitors specifically.
Examples.
Ritonavir showed decreased ethinyl estradiol, estrogen. Nevirapine decreased both ethinyl estradiol and norethindrone, progestin.
So what's the recommendation?
Avoid hormonal contraception as the sole method of taking ritonavir, nelfinavir, amprenavir, or nevirapine due to major interactions. Use backup.
What about others like efavirenz or indivir?
Minor interactions. The recommendation was for additional alternative contraception with efavirenz, but maybe not needed with indivir based on the data then. Studies were ongoing, like ACTG-317, looking at OCP-estipo's effect on zidovudine levels.
So choosing contraception is really complex here.
Very complex, many factors to weigh for each individual woman.
Okay, finally, let's touch on sexually transmitted infections. Treatment is mostly the same, but there are key differences.
That's right. We'll just focus on those differences. A big one is herpes.
How so?
In 1993, a herpetic lesion lasting at least a month became an AIDS-defining illness. That tells you something.
Infections are more severe.
Generally, yes. More severe, increased healing time, sometimes atypical presentations, and a cyclover resistance is more likely around 5%.
How is treatment different?
Episodic treatment is the same dose. But for recurrent outbreaks or daily suppressive therapy, slightly higher doses are often recommended. Long-term acyclover suppression, even up to 10 years, was shown to be effective and safe.
What if acyclover stops working?
Suspect resistance. Test for it. Acyclover-resistant strains are usually also resistant to valacyclover and famciclover.
So what's used then?
Intravenous foscarnet or topical cidofovir might be needed.
Okay. What about syphilis?
Also, increased prevalence in HIV-infected women. Neurosyphilis is more common. And being an ulcerative disease, syphilis facilitates HIV transmission. One model estimated hundreds of new HIV cases in African Americans in 2000 were attributable to syphilis.
Is treatment different?
Mostly similar, but with important exceptions. For latent or unknown duration syphilis, CSF examination before therapy is recommended.
CSF, cerebrospinal fluid.
Yes, a spinal tap. Also, if blood tests, non-treponemal titers, don't decrease properly after treatment, CSF exam is needed, and penicillin desensitization might be required for allergic individuals.
Any other recommendations?
Some experts recommended treating even primary or secondary syphilis with the 3 weekly penicillin injections usually reserved for latent syphilis, and considering a CSF exam even in early stages for HIV-positive individuals. HIV-infected patients are more likely to have treatment failure and often need longer therapy courses. Some specialists advise against single-dose options, especially if follow-up is uncertain.
And pelvic inflammatory disease, PID.
Early reports suggested it might be atypical, require more surgery, have higher mortality in HIV-infected women. PID with a tubo-ovarian abscess was even listed as a Category B symptom back in '93.
But newer data
shows fewer differences now. HIV-positive women might be more prone to tubovarian abscesses, but they generally respond well to standard outpatient antibiotic treatment.
So treatment recommendations are the same now?
For upper genital tract infections like PID, yes, the current recommendations are the same as in the general population.
This has been an incredibly thorough deep dive, pulling so much from Dr. Saktin's article. It really highlights how vital it is to understand these connections for providing good care.
It's fascinating, isn't it, how much our understanding has evolved, even since 2003 when this was written. Yet those core principles about the interplay between HIV, the immune system, and gynecologic health remain so relevant.
And as women with HIV live longer, healthier lives, the need for ongoing research and better treatments continues, especially for those recurring issues like the lower genital tract neoplasias.
Absolutely. And there's still clearly more to learn about that complex dance between sex steroids, HIV infection itself, and the immune system. How do they all influence each other?
Yeah. But it's encouraging that growing knowledge will help clinicians be better equipped, to counsel women effectively on everything from contraception and pregnancy to navigating menopause.
Definitely. Which brings us to a final thought for you, our listener. Considering all these intricate connections we've discussed today, what do you think are the most pressing research questions that still need answers? Where should we focus to further improve the gynecologic health and really the overall well-being of women living with HIV?
Something to ponder. It's a field that keeps moving, and thinking about those next steps is crucial.